السلام عليكم ورحمة الله وبركاته. أهلا بحضراتكم جميعا وفرصة سعيدة إن شاء الله. النهاردة محاضرة لطيفة بإذن الله تعالى، نرجو من الله ذلك. إن شاء الله بإذن الله تعالى me and Dr. محمود رزق will be with you. Dr. Rizq in the course already started the bowel, the GIT, and I think he is going today to discuss with you large bowel. Okay, and after he finished his part I will هبدأ أنا معاكم إن شاء الله الجزء الخاص بالinvestigations. Next step in the bowel. ان شاء الله تبقى محاضره لطيفه. في نهايه المحاضره برضه هيبقى معانا few questions to discuss together, especially في البارت بتاعي. So you can also manage this. يبقى كده في تنوع برضه في المحاضره ان شاء الله. I think يعني طبعا ان المحاضره محتاجه تركيز، لان طبعا انتوا عارفين ان الموضوع محتاج يعني كويت مليء بالمعلومات، فمحتاجين نبقى مركزين ان شاء الله تعالى في سماعها، وان احنا طبعا نبقى مركزين مع الملاحظات اللي احنا بنقولها والتيبس والتريكس اللي في بتبقى هيدن اثناء المحاضره يعني. دكتور محمود, if you are ready to share your screen and start.
Okay, just you can open screen share.
Yes, yes you can.
Assalamu alaikum, inshallah everyone is doing well. We are happy to be with you today, inshallah, for to a course continuing our journey. Last time we was talking about trauma in the bowel, and we stop in such image, and as you know, this the voice is okay. Starting بس قبل ما
Yes, yes, Dr. Mahmoud. Yes.
ماشي. Okay. We continue until we reached to the chapter of trauma in the bowel. We are following the crack the core, making some comment. These comments are usually have some tricks, some tips to be more informative and more focusing in the exam style. So we're talking about something very important in the exam is called the shock bowel features. As you see in this image, he might give you a case and talk about feature with thick enhancing bowel loops, and you might note that this enhancement usually is in the mucosa, and this is very characteristic to see it in the shock bowel syndrome or shock bowel disease. Plus, if you find the flattened IVC as you see here, and also if you go more up, you check the adrenal gland, you can find that the adrenal gland is hyper enhancing usually. So this is important question in the exam, and come in the MCQ, as you will find some clue going with this, as he might tell you about someone who have a coma or he have recent trauma and so on. Then he did a CT and give you the finding of these pictures. Then if you shift with me, if you are following me in the crack, we were talking about this appearance. Also one of the exam questions, he told you about that there is a thickening in the bowel. Patient maybe have a history of AIDS or autoimmune disease, maybe have a history of Crohn's, usually the high risk factors. Anyway, they will give you finding that this patient have thickening, usually it's diffuse thickening or massive circumferential thickening, but there is no obstruction. Then you have the most common or most likely diagnosis. If you see this image, if you can in the chat suggest any typical features for this image. Anyone know? Can share with us any ideas?
Hypovolemic shock.
No. I mean this patient who have circumferential thickening, you are worried about, is it like a mass lesion? Usually we think about carcinoma, like a cancer, or maybe we can think about lymphoma. Okay, so if we think about either both diagnoses, we need to differentiate in between. And usually in the exam question, there is some keyword that give you a clue. If you find it like here, diffuse circumferential, so everyone will be happy if we mention that is most likely lymphoma. Then the question, why? Why is lymphoma? Why is not carcinoma, not adenocarcinoma? Usually the lymphoma have feature that there is no obstruction, as you see here. And it have another characteristic, especially in the small bowel, with this image feature. I don't know if it's obvious, clear image or not, but you'll find like there is aneurysmal dilatation. Then there will be dilatation, even no obstruction. There will be aneurysmal dilatation. Excellent. Yes, bravo. In the chat, yes. So this is typical feature of lymphoma. Opposite, in the opposite side, adenocarcinoma have usually focal, not diffuse, thickening, and usually there is obstruction. That's why, if you remember with me, that sometimes we have intestinal obstruction, secondary to what? Secondary to carcinoma. Yes. There is another question in the exam, also in the bowel. You might find lesion. They will describe it for you like a mass, and this mass have around, there is a desmoblastic reaction, and it can have also calcifications. And the most common location of this lesion is distal ileum, but it can also happen in the appendix. And usually there is some serotonin elevation. There is now some nuclear scan. They can add much value in the assessment, evaluation, and also the treatment, like the gallium dotatate. We are talking about the carcinoid. Yes. The MIBG or ectoriotype scan, and now there is a gallium dotatate scan, which is more recently accepted. So this is the typical feature of carcinoid. As you know, there is a carcinoid and there is a carcinoid syndrome. If there is high serotonin level, what do you expect to see in the patient clinically?
Liver metastasis.
Yeah, I just suggested to make the chat because this is recorded. So if you write in the chat, it will be better. Anyway, thank you for your contribution. Yes, so we will have this patient have usually in the history something in the keyword about, yes, diarrhea or maybe flushing. Yes, exactly. So this is the typical feature. If you find anything in the clinical picture in the exam question about this, then your mind should go to talk about such choice of carcinoid. Carcinoid is considered as a well-differentiated, one of the most well-differentiated neuroendocrinal tumor. So also if the answer is neuroendocrinal tumor, you can choose it because carcinoid, one of the most well-differentiated neuroendocrinal tumor. And also a good trick that I will tell you also that is good to mention, because also is mentioned in some exams, or is a good exam question, to be honest, that if you do FDJ, PET-CT for this patient, what did you expect? You expect this patient have high uptake in FDG PET-CT or not? What do you think? Yes or no? High? Yes. Yeah, perfect. No. The answer is no. Why? Because carcinoid usually is a well-differentiated neuroendocrinal tumor. So if there is carcinoid, so usually will not be typical uptake in the not very high or not even uptake, a good uptake, metabolic activity in the FDG PET-CT. In the opposite, that's why we need to do octreotide scan or maybe MIBG, or recently there is gallium dotatate PET-CT that showing a high uptake in these tracers. Okay, so FDG PET-CT usually in the carcinoid not typical to have high activity. Okay, so let's go shift in another exam question. Another exam question about the types of hernia that usually happen. And you will find that he mentioned many types like Spigelian hernia, if I mention it well, if I name it well, and lumbar hernia, Litter's hernia, and Richter hernia. All this, like, it can can be a good exam question, especially if I show you something like this. Let me show you what I want to. So this patient, if you agree with me, have critical situation. I don't know if you agree with me or not that he has right now a critical situation. What the critical situation he have? Anyone knows what it could be? No? There is dilatation in bowel loops, if you agree with me. Yes. And in that such dilatation, I will check what could be the reason. If you remember with me the last time we talked about this, if we think about mechanical obstruction or if there is ischemia, and we talk about that you have to check first for ischemia, and this is what you did. So perfect. Okay. So if there is a mechanical obstruction, then you have to check for the sites of hernia, sites of hernial orifices, and you should check for if this patient have hernial protrusion, and that could be the reason for obstruction. So in this patient, you have one type of hernias. If you agree with me, you can see the hernial orifice here, and what it could be, either inguinal or what is called obturator. Yes. So we are talking about inguinal or femoral or obturator hernia, such this one. And the history, usually they give you a history that this patient is an old lady who have maybe COPD, or maybe she's pregnant, or she have a chronic cough. Then this patient developed obstruction and go to the ICU or go to the ER, and they did for him the CT, and the patient have intestinal obstruction. Then you have, if you go to the crack the core, you will find that there is a good table about how you can differentiate between the femoral and indirect hernia. And I think this is also a nice exam question to be taken in the exam. Okay, so intestinal obstruction, either to mechanical or ischemic, very, very important questions. You have to have a nice approach how you can, in the situation that you find that this the question talking about intestinal obstruction, You have to find the most common, what it could be, why. And there is one cause of, again, let's say that localized bowel obstruction. We talk about this last lecture, but let's focus about this, that if you find the clusters of dilated bowel loops in abnormal location, and he told you, especially in the keyword in the question, that this patient have surgery, especially the bariatric surgery, then you have to think about one of the most common internal hernia. Yes, you have to think about internal hernia. Internal hernia usually happen like predisposing for this issue, that the patient, if he have previous surgery, especially now bypass surgery, one of the common situations that can happen. So sac of clusters of dilated bowel loop, and the most important to check for the mesentery, the mesenteric artery. As I mentioned to you the last time, first check for the ischemia. Then after you check, if you find that the mesenteric vessels are enhancing and patent, you have to check for the location. Because if you find abnormal location in patient with bowel obstruction, and you have abnormal location between the artery and vein, so maybe you can think about that it could be one of the types of internal hernia as well. And this is again one of the exam questions. Okay, so if we go more deeply and we shift, if you go with me in the crack, you'll find that he shifts to the large bowel, especially if you go and find such image that usually is like frequent spotting image. He will talk about the patient in the keyword. This patient, he might have clinical picture giving you characteristic picture of lead pipe bowel with loss of haustrations, and usually it affects the rectum. We are talking about ulcerative colitis. Usually there is, in the exam, you will find yourself between two major entity, either Crohn's or ulcerative colitis. There's some keyword that help you to think about Crohn's, especially if you find that it is come in the most likely site along the terminal ileum and ileocecal junction. Also, if you find something in the keyword about the gallstones, or this patient have a history of pancreatitis, of abscess, hepatic abscess, all this can give you a keyword that he talk about Crohn's disease. Affection in the rectum, usually it is ulcerative colitis. And then you find like very famous table, how you can differentiate, or what the keyword more going with Crohn's and what the keyword more going with ulcerative colitis. Then I want to show you something very common, to have it like a clinical scenario. this image. So if you find like this patient who have, as we mentioned, lead pipe appearance, and there is loss of haustration, and this patient right now, he had a complication. What could be the complication that you are talking about? Yes, toxic megacolon. Then you have to know that it is not allowed to do in this patient barium enema, because this patient is a risk for
Perforation and obstruction.
perforation. Yes, thank you. Better in the chat, but okay, thank you. And this patient also have like frequent to have peritonitis. So you have to think about toxic megacolon as one of the features that we have to think about, especially in ulcerative colitis. In the exam also, they have one question. Let me show you like image about that there is misty mesentery or misty fat around the lesion, like this one. Usually it happens in the left side of the colon, but it can happen also on the right side, and affect the serosal surface of the colon. Yes, it is. So you'll choose epiploic appendicitis. Usually it affects the left side. If you find in the right side something similar, maybe then you can think about the omental infarction, which is more common in the right side, right omentum. There is again misty fat in the right iliac fossa, and so you can think about the omental infarction. Usually self-limited. But before you think about mental infarction, you have to exclude carefully that this patient can be appendicitis, because it's very close location. So you have to see first that the appendix in this patient is clear. If you find the appendix is clear, then you have the right to say that, okay, it can be totally pure in the fat, then it can be yes, omental infarction. Then if you tell you in the situation of the question or the keyword that this patient have cystic-like structure in the right iliac fossa, and in the ultrasound have layering appearance, so in that case we could suggest something very common in the right side is called appendiceal mucocele. Yes, if this mucocele is ruptured, there is another condition happen in that case. If this mucocele rupture and disseminate, anyone know what could happen, what the situation will be? Then this patient can have pseudomyxoma peritonei. Yes. Then if you find pseudomyxoma peritonei as a final picture of this patient, then you can suggest that this patient could have underlying tumor in the appendix, and this is the reason for that. Then if you go with me in the crack, you'll find he go in another chapter, which is very important. This is about types of volvulus. And you will find that there is two types very, very critical and very important also in the exam. So we are talking about either cecal volvulus or sigmoid volvulus. And then how you can differentiate in between. Usually the cecal volvulus in younger age group and pointing in the left upper quadrant. And the most important, to be honest, that go check for the cecal and also go check for the subsequent process, what will happen. Like you know that in the cecal volvulus, there will be dilated small bowel loops as a subsequent process. And if you go to check for the sigmoid volvulus, you will find that in the sigmoid volvulus, usually the affected is there is absent air in the rectum. And if there is a volvulus, there will be dilatation of whole colon. And the sigmoid volvulus is most common, especially in the adult, and more critical. And even they call it grandma volvulus, as usually affecting the old age. Okay? Usually pointing in the right upper quadrant, opposite in the for the cecal volvulus. But anyway, both of them, they are common to be asked in these points. Okay. There is one situation, maybe I can show you a picture of this, like type of condition that this patient have a chronic dilatation, not acute, chronic dilatation, and even chronic marked dilatation. And there is no transition point. There is type of ileus that can affect, yes, exactly. This can affect the colon, Ogilvy syndrome, or colonic ileus, or colonic pseudo obstruction. Okay. Usually, patient who have like marked, as you see, marked dilatation of the bowel loops, no transition point, no leading point, as you see here. Sometimes you can see such appearance in the even the practice. It's not a good sign to see it. Then the keyword in the question, if you find something about procedure, like surgical procedure, recent, yes, recent surgical procedure. So we are talking about missed towel or Gussie by Boma, as you call it. In the X-ray, maybe you can find the threads of this retained surgical sponge or whatever, and around inflammatory process. So the keyword will be the surgery in this case. If they told you in the barium that this patient have a coned cecum, then this is very characteristic of infection, which is very famous infection called exactly, yes, the TB. Perfect. So this is what is called coned cecum. If you find that this patient have diffuse thickening, especially in the cecum and maybe the terminal ileum, and this patient have history of leukemia or having chemotherapy, and the picture of this patient blood picture have severe neutropenia. So there is one thing, infection, type of infection that happen especially in the patient who have chemotherapy, or it's called typhlitis, or the other name is neutropenic colitis, typhlitis or neutropenic colitis, usually affecting the cecum. In the large bowel, as we talk about the small bowel, there is types of cancer that can happen and make the picture of apple core, or in general, there is a shouldering. And usually the colon cancer can metastasize to the liver and giving in the liver like a target sign. And if you find like type of cancer in the colon, you have to check for other types. You have to check for other, sometimes there is a synchronous affection. Like if you find like in descending colon, there could be another one. So don't be satisfied. It can happen that this patient can have multiple affection in the same time by colonic cancer. Then they call it synchronous affection. Yes. And I forget to tell you something about the Crohn's. One of the key also, if you find like a segment of affection in the Crohn's, you have to search for others, because you are thinking about one of the situation common in Crohn's that happen again. It's called skip lesions. So again, one of the characteristics, yes. We talk from maybe a few minutes about the appendix, and if there is a rupture happen from mucocele, or could be there is a mucinous neoplasm in the appendix, or others like ovary, colon, pancreas, and it can affecting with dissemination. There will be peritoneal affection, then there will be scalloping along the liver surface. Then this patient have what is called pseudomyxoma peritonei. And one of the common also situation that can affect the peritoneum as well, the peritoneal carcinomatosis. And then you have to search for either primary carcinomatosis, or it can be secondary from metastasis like the ovarian neoplasm. So you have to search for the reason. Either ovarian, colon, or even sometimes breast. And if it is primary, then there is like something called primary peritoneal mesothelioma, like primary peritoneal disease. If you find cystic lesion or hypodense lesion, low attenuation lesion, and it looked like a cystic lesion by ultrasound, then they did CT, and this lesion related to the bowel, then you can think about what's called duplication cyst. If there is a previous surgery or a surgical site, then we can think about like called lymphocele, yes. And if this patient have history of pancreatitis, then you have to think about pseudocyst. And if it is multilocular, you can think about lymphangioma. If it is a solid lesion, and again, it is related to the bowel, and they give you the question that there is a solid lesion arising mainly from the bowel, then you have to think about the, yes, exactly, GIST, gastrointestinal stromal tumor. And we talked just few minutes before about carcinoid, and last lecture we talked about the desmoid as well. Okay. I think we have some like a general tricks, and I will leave you now with Dr. Muhammad. Today, inshallah, he will continue with you the next step and investigation. I wish that you have any benefit from this short comments today. Inshallah, next time it will be more detailed, and see you soon, inshallah. Leave you now, Dr. Muhammad, to continue.
Okay, thank you Dr. Mahmoud, and يعني I am يعني أنا سعيد جدا بالتواجد مع حضرتك. Thank you for being with you, and يعني despite your illness, I think alhamdulillah you recovered now, يعني partially. Thank you for this one. And we are before this lecture, and we are not uncertain that Dr. Mahmoud will be with us as he is having some cold and his voice was affected. Thank you, Dr. Mahmoud, for this effort. Thank you very much. And
Thank
I'll
you.
share with you my screen now for the second part. I want you all just to take and hold a deep breath before continue. This part of the lecture will focus on the investigations that performed for the bowel, and we will share this together. I'll start sharing my screen now. As you know, next step is one of the uh, 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 and investigations and what to do in the next step is one of the common exam scenarios and questions that comes in the exam. You can see my screen well. I hope that you can make it just a second. Let me make it yes, to be more obvious. I think now more can see it more. So I need to make it like this. Yes. Okay. So you can read with me. Okay. Regarding this part of the questions, it's very sometimes it's very hard because it depends on the clinical scenario of the provided in the questions, and it depends on the details of the clinical scenario. So okay, we are back. Thank you very much for rejoining. Sorry for this technical issue happened. So as I told in before this end, this part of the questions is very noisy and causing significant headache for us during our preparation as well. Because as you know, even the sources available for the exam, like Crack the Code, most of the candidates are using it. Even in UK trainees are using Crack the Code as a source of the final revision of before going to the exam. This part of questions or this type of questions is quite headache for all candidates. Because as I told, it depends on the scenario of the clinical provided in the question, and it will be very tricky in the scenario. You may miss information or a point that will affect the choice. As you know, the questions are best selection, the best answer. So maybe 3 or 4 of the options can be used in this scenario, but it will be depends on some criteria inside the question will allow you to choose one of them, to make one of them the best choice in this situation. So to know the basic knowledge of this investigations, well, it's very important and quite you need to focus on them. To know the indications, to know the contraindications, to know about the technique itself, the varieties. So it's very important. So we are going to share some information regarding the bowel examination, especially with contrast media. And then we'll have some questions on this topic, which is noisy even in the routine work. If you are dealing with fluoroscopy or dealing with contrast media, even with CT scan. So I will start to show you a quite information or some information regarding the contrast media itself. So the contrast media barium sulfate, this is one of the most common used in the GIT examination. As you know, the concentration, the important regarding this part of this this information, and you may find some information is not necessary, but it's important to be in the context to know the background if you want to have an access to something complete. But the important regarding the exam will be the concentration and what you use when you are selecting one of this investigation. So the variation will be in the concentration of the barium itself. So when you are using barium swallow, you need something viscous and to have to see the mucosal details. So you will use 250 percentage one. Okay. If you are going to use the barium meal, barium swallow and barium meal are quite identical in indications and in uses. So there is no wide difference between them except in the technique of imaging itself. So as he told here, a double contrast study requires a high density, low viscosity barium to give a good quality thin coat of the mucosa. So to determine the mucosa itself, you need a high density and low viscosity barium. So this is will be in the 250 concentration. If you are going to use barium flow-through, so you need it's more liquid, and so you need a lower concentration, like 60 to 100%. Okay. For enema, you need a small bowel enema that for enterocolitis, you need no more than 60%. And he is giving here the trade name that are using in the market, and sometimes maybe questions will come with these names. So you just need to memorize this one also in your preparation. Barium enema, you will need this concentration also. This is to memorize. It's very important because as you will see with me, a sample of the questions will how this come in the questions and how to deal with them. So it depends on how to memorize this and to know the specific indication for each one. The advantages of barium using in general is to make an excellent mucosal coating compared with water-soluble components. So it will give you a more details about the mucosal pattern. As you know, the endoscopy is replacing this in the routine work now. So even now in our hospitals, we are not using this so much, but you may need this if the endoscopy is contraindicated or difficult to be used. So you must know about this investigation, and this can come in the scenario of the exam, as we will see in the last part of the lecture in the sample questions. Okay, the disadvantages, it depends on the complication and the limitations of this study. So the problem is with barium is high morbidity when there is any risk of perforation or spillage of this barium to the peritoneal cavity. So, and if you are going to make extra investigation, you found in after you did the barium, you found this is not specific, not giving you not answering the clinical scenario. So you need to go to proceed to CT scan or ultrasound. This will be very difficult using this investigations after barium because because it will give very high density, and this will alternate the value of the other imaging like CT or ultrasound. So it will render it impossible because dense barium within the GIT tract attenuating the X-ray or ultrasound beam. So it will be very hard to do any investigation after barium. So before you are going to decide to use barium or not, be sure that you are not going to extra investigate the patient with CT or ultrasound. Also, one of the important issues regarding this, and this is a very quite common question asking, the complications that come with barium use. So you have a mortality, this is very rare, I know, but it can happen. Perforation also is very, if the patient is having obstruction or something, or it's not quite clear before you are going to use barium, this will complicate the situation. And the patient may go to perforation, and if go to perforation, then quite common problem will happen, it will continue to have a high mortality or from the peritoneal contamination of the barium. Even if you are using the measurements like fluids or steroids or antibiotics, as he told here, but this is quite problem happen. If the patient survive from this, he can develop adhesions, and this is also may lead to further complication in the futures. Also, if the patient is taking contrast, especially in barium swallow and barium meal, and the patient aspirated, it will have induced pneumonitis and granulomas Okay, and this is also very risky for the patient. Intraposition also to the vascular or to the vessels can raise the possibility of barium pulmonary embolisms will be very seriously, and you can see that 80% mortality. Okay, so what is the alternative for this one? Is the water-soluble agents. So you can use gastrografine or others like gastromil. Okay, and we'll come to each one of them and when to use this and when to use this. Okay, so what is the difference between them? The gastrografine is higher in the osmolarity and the gastromil is lower in the osmolarity. As you can see here, it's 370 milligram per milli. Here it's lower, 300 milligram per milliliter. So it's low osmolar and it has a reduced risk of osmolar effects that you can see here. So the water-soluble compounds itself, it have a quite indication that it's very important in the clinical practice. And you are using the water-soluble, in fact, using this during your preparation, even if you are going this examination with CT scan. So you need water-soluble contrast media more even. So if you are suspected in perforation, so you can use gastrografine, and it's very less contraindicate or it not having a lot of complications like barium. It's very safe as compared to barium. So water-soluble, it's your choice here. If the patient is having meconium ileus, something like this, it will have a laxative effect, but you may be sure that the patient will not be dehydrated from this one. So if you are going to use this in meconium ileus, especially neonatal age group, you are going to dilute this to make it more low osmolar in the effect to prevent the shifting of large fluid shifts and making a very quite problem to the child itself as well. Okay. As I told you, can use this with the CT scan. If the aspiration is possibility during using water-soluble contrast media, you can't use gastrografine. You will use gastromiro instead of this because this will reduce the risk of pulmonary edema. Okay, so one of the important issue here also regarding the complication, the potential complications of using water-soluble compounds, it will include pulmonary edema. Okay, and if aspirated, yes, if aspirated during any investigation you are going to do, pulmonary edema will be one of the important complications. How to reduce this risk? By using gastromiro. So if you have a patient who have a risk of aspiration from the question, and you have the choice now to have gastrografine or gastromiro, you will use the gastromiro one. Okay, hypovolemia in children. Okay, you can because the osmotic laxative effect, as I told you in meconium ileus, if you are not going to dilute this one, what will happen? The patient will go to have hypovolemia because the fluid will be shifted from the bowel to from outside to the bowel due to the osmolarity, and the patient will lose fluids and the patient will have a serious problem. Okay, allergic reactions also because it's contain iodine, also one of the problems. One of the important agents you are using during the study is carbon dioxide, which is very important to have a double contrast effect, and this one it's quite giving you a contrast between the mucosa and the lumen itself, so you can have more details about the context. Okay, let's move. These things are not quite common and it's just for reading, so we just skip it. Okay, if there is any contraindication for this CO2 double contrast, yes, no obsolete contraindication, but there is relatively contraindication, such as the patient is having high-grade intestinal obstruction. So this is gas. The patient already is distended, so you are going to inflate the patient with gas again. So you may induce rupture in this high-grade obstruction. So if you have a high-grade intestinal obstruction, you are not going to use carbon dioxide as an agent for your investigation. If the patient have a fund duplication, also it's uncomfortable for him to give him a gaseous contrast agent. Okay, go. Yes, no. Okay, let's go to specific. We finished. Now we will go to each examination itself and to see what is the indication and what is the certain. This is what will come in the exam. Okay, so the barium swallow, as you know, it's the investigation to examine the esophagus and the swallowing action. So you will need this to check the function of the esophagus as well as the anatomy of the esophagus and to delineate. But this is replaced by endoscopy, as I will tell you now. I will tell you now. Barium meal also is a radiological examination for other GI tract, especially stomach and duodenum. Okay, but you will have some assessment, and many times it's combined swallow with barium meal. So you will have an assessment of esophagus, and mostly we are going to do a swallow, then we are going to complete it by barium meal. Water soluble contrast swallows and meals are also performed when it's unsafe to perform barium examinations. That's what I mean. It will happen. It will come in the exam scenario. Okay, so if there is a risk of aspiration or perforation or prolonged stasis, so you are not going to use barium. You are going to use water soluble contrast swallow or meal. Okay, or if the surgery is imminent, and if you are going to make a surgery for the patient, don't use barium, because if you are going to use barium, you will complicate the action of the surgery, and the patient, if have any spillage, so the patient will have a serious problem from barium. So if the patient is having potential to surgery, don't use barium as a next step investigation. Okay, fiber optic endoscopy. This is routinely used instead of barium examination, in fact, and it's considered the golden choice now in the endoscopy. You are going to use these studies if the patients are not fit to have endoscopy. So you are going to use this. It's important also that if you have a functional information, if you want a functional information, you will use contrast media in your swallow examination if you want to assess the function. So if the question is asking about the function, it's not endoscopy, it's not CT, you need to use swallow. Post-operative patient also will need this investigation to examine any risk of contrast extraposition. So what is the indications when we are going to use this one? Okay, if there is a sensation of lump, dysphagia, reflux, hiatus hernia, to exclude peptic ulcer and gastric pain and persistent vomiting, you will find the swallow and meal in the next investigation. When to use them if there is another clue in the question that preventing you from using the routine or the gold standard investigation or investigation of choice in the scenario of the question. And this will come in our samples of questions after a while. Okay, so this is if there is a perforation, post-operative assessment, fistula, all these are indications for a swallow and meal. Okay. Okay, so which contrast are you going to use? As we told, we have multiple choices. We have barium study, okay, and this is single barium study without double contrast, and this is must be high density, low viscosity, as we told. It will come in 25 percentage, okay. 250%. in the first schedule. As I told you, it can come in the exam with this trade name. Okay, so you must know about this. Barito is a double contrast examination, but less dense coating. Okay, because it will have double contrast media and water soluble contrast media, gastromeru or gastrocopine or omnipaque. All of this can be used in the as a water soluble contrast media for your investigation of the upper GI. You will need also this for gas, like if you are going to do double contrast, you may need compression bed, but this is very important and quite frequently asked in the examination. Buscopan, you need this 20 milligram. This is a very common exam scenario, exam question, and this is intravenous. And this is have an anti-muscarinic, inhibits intestinal motility, and relax the pylorus and the duodenum. Marshmallow also can be used as semi-solid bolus challenge. There is something you are, but this is not necessary to know that. Okay, double contrast also, it's have the indications here and contraindication. The indications are similar: dysphagia, reflux, esophageal dysmotility. Okay, if you are suspecting esophageal dysmotility, this is a functional. It will not be monitored during endoscopy. Endoscopy will not help you in this case. So you need here contrast study like swallow or meal or even one of them. So post-operative check, you are not going to use this barium during this because there's a liability of perforation or aspiration, and this is or leakage, and this is will have a very certain complication. Okay, the double contrast barium meal is same as swallow. Okay, so there is no difference, major difference. You need to know about the contraindications if there is a risk of aspiration. So, or even there is like good gastric outlet obstruction or gastroparesis. This will be very risky for the patient. If this is in the exam question, you will have to check this carefully. This is quite common in the exam coming to give you a clue in the image or in the question that tell you that the patient have a risk of gastric outlet obstruction and what is your next step to use. And this is very quite. You have an examples will come now. If suspected gastric or esophageal perforation or leak following surgery, you are going to use water-soluble, not barium meal. Okay, this is a question, and I want you to share with me the answers in the chat. This is one of the questions. What is the which of the following is not a contraindication to Buscopan? Buscopan is used during your examination of barium swallow or barium meal. You are using Buscopan to relax the muscles. So there are multiple contraindications for this one. Which one of this not contraindication of Buscopan? This is the problem of these questions. It's quite away from the imaging features and how to diagnose. It depends on the clinical. If you are not reading this and doing this, so you will have a very big problem dealing with them. And this is the problem in the exam. This is the most common cause of failure, unfortunately. Okay, someone is telling glaucoma, and the other is telling that pyloric stenosis. Okay, I think the answer is diabetes. Okay, because all of these others are the contraindication. And here you found this, the correct answer is B. Buscopan acts immediately after IV injection. That's why we are giving it immediately, and then we started. When we just inject the patient, we can start the procedure immediately. So because the action is very quick, so that this is have a short duration of action. So it will relax the muscles. So you can do your examination with good one. Okay, what is the what are the contraindications? This is myasthenia gravis, closed angle glaucoma, paralytic ileus, pyloric stenosis, and prostatic hypertrophy. And if you don't know this information, you will not answer it in the exam. This is a problem with this kind of questions. Okay, and here it's very important alternative. They may ask you about this. The patient have contraindication for buscopan. So which one of this you are going to use as alternative? Glucagon is the alternative. Barium meal itself is contraindicated in complete large bowel obstruction. If the patient of the scenario is having large bowel obstruction, complete one, and there are features in the question suggesting that the patient have complete large bowel obstruction, you must exclude barium meal from your because it will complicate the problem. Barium should not be used where there is suspected perforation intramediastinal and intraperitoneal. Barium results in high mortality and morbidity, as we told, and water-soluble contrast media must be used. Okay, one of the investigations that are using, and it can come in the exam also as one of the choices, and you must know about them, is endoscopic ultrasound, because this is one of the investigations. Even if the radiologists are not doing it, but in UK, you are part of the team. So you are attending a multidisciplinary team, and you are discussing the alternatives and the best choice for the patient to be used. So you must have a wide knowledge about the investigation that used around radiology, not in the radiology department itself. So you must know about what is the benefit of endoscopic ultrasound as an example. So this is very important and quite common in the exam to be asked. Maybe one choice of the, so it may be one of the choices you must know about it. So what is the indications and what is the are the contraindications of using endoscopic ultrasound? It's currently used for cancer staging, and you found here you maybe need nodal assessment. Is a main indication. You can see this statement is very important. Nodal assessment is the main indication for endoscopic ultrasound staging of lung cancer. Okay, this is quite surprising. Okay, so we are using this as a main indication for this study. Idiopathic acute pancreatitis, it can be used to exclude small stones if the patient is negative in ultrasound. So you are using this to be sure there is no cause of this pancreatitis, and the others like celiac plexus block for pain relief. Okay, contraindication, it's maybe not important. Okay, what about the barium examination of the small bowel? We talked about the swallow and the barium meal. Now the small bowel examination by barium. It has two terms, enterocolitis, this used in North America, small bowel edema new. Okay, this is very important statements that come in the exam scenarios. Barium meal is used to image the stomach and duodenum. This is quite simple. Capsule endoscopy uses a swallowed value capsule and does not use X-rays or barium. It's very important. Okay, magnetic resonance enterocolitis generally uses contrast agents other than barium. Yes. Being oral name or colon is a technique. This is very important to have a question. Come in the exam, this one. So, is a technique where the colon and terminal ileum are inflated with gas at the end of barium follow through to give double contrast views of the distal ileum. If you are having an issue with distal ileum and the patient need to have a double contrast, how to make this one by this technique. Per oral pneumocolon, this will inflate the terminal ileum with double contrast, the barium and the gas. So you will have a more detailed image for the terminal ileum. Also, this is advantages and disadvantages of each modality, and it's not important. Regarding the contrast examination of the colon, colon have a very wide range of investigation can be used. Colonoscopy, the the very common one. So, and colonoscopy will give you can give you a tissue biopsy, so it's the investigation. But the problem is when the patient is not liable for this colonoscopy, the question will start asking you, what will you use? Single contrast barium enema, or you are going to use double contrast barium enema, or you are going to use CT colonography, or you are going to use MRI colonography. So it depends in the clinical scenario itself. The radiological investigation of the colon has the following rules in the patient care. You can use this radiological investigation in these indications: detections of polyps and colorectal cancer, okay, follow-up screening for post-operative colorectal cancer, because the patient will have maybe have risks for many things. So some centers are using, many centers or most centers are using colonoscopy, but sometimes it's failed or it has a risk of perforation or something like this. So you are going to use other alternative method. You can use it for evaluation of the particular disease, investigation of suspected anastomotic leak or perforation, and it's similar, I think, as all this. Here is very important information. The radiological investigation of the colon is not generally performed in patients with inflammatory bowel disease or bulbosis coli syndrome, unless there is a specific indication like investigation of fistula. So this is a very important one also. This is not routinely used or generally used in these patients, except if there is a certain indication like fistula, you can use them. And here also, this is important regarding some important information about single contrast barium enema. Single contrast enema, it's performed in 3 indications: to investigate suspected anastomotic leak perforation or to exclude anastomotic leak before surgery, or to differentiate between true large bowel obstruction and pseudo obstruction, to investigate colonic fistula with or without CT scan. Okay, a barium suspension is not used for the investigation of the above condition due to the potential risk of barium within the peritoneal cavity. You are not going to use barium in these patients. You will use water soluble instead, so if the patient have the risks of perforation or leakage. So here is a very important key points. Colonoscopy remains gold standard investigation for large bowel because it will have a combining diagnostic and therapeutic potential. It can allow you to take a tissue biopsy. It can make an excision of a polyp or something like this. CT colonography, it's using as a screening in the screening as a screening tool for the some population if they fail to use colonoscopy. Okay, so they will in the question itself. It will be you will notice that the patients have some sort. He will tell you that the colonoscopy is failed. So what is your next step? MRI is not using now. It's not. They are planning to use it in the future. The important issue here regarding CT and MRI is they are both provide intraluminal and extraluminal imaging. And here, after this, we are going to make the part of the questions. We finished most of the. Okay, so this is the first question here. This is one of the quite complex exam questions, in fact, because it's have a complex answers. Which of the following are fundamental technique parameters for the performance of optimized virtual colonoscopy? A, the single slice CT scanner, bowel preparation, colonic distension, dual positioning, and the ability to review in 2D. multi-slice CT scanner, the same bowel preparation, colonic distension, dual position scanning, and the ability to review in 2D or 3D, then single slice, no bowel preparation. We start to play in these parts. So what do you think? What is the correct answer? Okay. B. B. Okay. Yes, B. That's why multi-slice. So simple. Okay. So, and this is the fundamental technique parameters here. It's multi-slice CT scanner. You need collimation less than 3 millimeter. You need bowel preparation. You need colonic distension. How to use this? You will use Buscopan 20 milligram, okay, and you need an automated inflation via thin flexible rectal catheter. You will have dual position supine and prone lateral decubitus. That's facility to both 2D and 3D. So all of this are the technical parameters you need for virtual colonoscopy. This is some kind of the questions can come in the exam, asking you about your ability to determine which is the next. Here it's about the abdominal radiograph. I don't think we are going to use this all, but I'll give you a sample before going to the question part. Abdominal radiograph, this is very important to know. Plain films are commonly undertaken in two main contexts. Okay, a primary tool investigation of acute abdomen. So it's the primary tool there. So you can use it as a control film in other studies like urogram, IVB, or something IVU like this. Common indication of abdominal X-ray in acute settings are if you are suspecting bowel obstruction or renal colic or suspected perforation of hollow abdominal discs. If you have a suspicion of other complications, you may ask for supplementary projections. But this is not routinely performed. You are not going to examine the patient erect from the first instance. You need to do a supine film first. Then you may ask for erect chest radiograph for pneumoperitoneum and air under the diaphragm. You may need erect X-ray to see any multiple air fluid levels. You may need lateral decubitus, especially in left lateral decubitus, especially in babies, to examine any free air or subtle free air like this one, shining short through projection. This is very rare to be used. Okay, you will need this in pneumoperitoneum, such as features of abdominal X-ray in pneumoperitoneum. It's very important to know about this one. One of the important things that you need the patient to stay 10 minutes to allow the gas to accumulate to the highest point. So this is very important. So if the patient is ill, you may use left lateral decubus and not putting the patient in the erect position because he may be ill and can't be stayed for 10 minutes. Okay, let us going quickly through this. I need to go to this is all about how to, this is not next step, this is the criteria of the disease in X-ray. So now we are with the questions. So this is the first one. This is an 89-year-old female patient is referred by the surgical team on call with a suspected large bowel obstruction. The CT scanner is being serviced. CT عطلان واحنا هنعمل للبيشنت contrast media. So which options are appropriate for these patients? I think in the exam it will be one option. Okay. So, which option you are going to use? Gastrographene, barium, 2B2, barium 250, barium 115, barium 60%. Okay. Okay, as we told, the patient is suspected for large bowel obstruction, so all barium will be contraindicated. All barium depends on here the answers and how this reflect the informations we are mentioned in the first or the beginning of the lecture. Okay, so this is a good single contrast agent for large bowel obstruction. If perforation is there, so it's not a big problem with us because it's a safe one. Okay, so we are going to use water-soluble contrast medium. All of this, okay, can have a risk of the patient having perforation, and this is maybe suspected complete large bowel obstruction, so that it's contraindicated. Okay, all of this have the colonic investigation. You can use it for the colonic investigation. This is not used in the colonic investigation because it's very thick, viscous, and high viscosity, and so it's very the patient if have risk of barium peritonitis, if any, and if the patient is going to have surgery, it will be a very problem because large bowel obstruction. You are expecting that patient maybe go to OR, so you are not going to do a barium for the patient to complicate the situation for the surgeon. Okay. Okay, so they all have risk of peritonitis during the surgery because of the leakage. Okay, this is another question. This 49-year-old male has developed chest pain which is non-cardiac and a pyrexia 10 days after this esophageal gastrectomy for esophageal carcinoma. The patient is having esophageal carcinoma and did an esophageal gastrectomy. The clinicians wish to know if he has an anastomotic leak, swallow is requested. Which option or options are appropriate? Also in the exam will be one option only. No, the patient may have may need a surgical investigation. So they are telling you the patient may have a risk of perforation. And most of the causes, because the causes of large bowel obstruction, most of them are volvulus or a mass. So most of the time it's high-grade obstruction. So you are worried about perforation, in fact. And if there is no perforation, there is no risk of perforation, there is high risk that the patient will go to surgery. So if the patient goes to the surgeon goes to surgery, they can take some of the bowel. If there is ischemia or something, so it will be a leakage of barium. This will cause peritonitis. That's why. So there is anastomotic leak. This is be in the mediastinum. So I worry about the patient may have a problem with mediastinitis or aspiration. So gastromeal will be more safe. Yes, agree with you. There is risk of pulmonary edema if aspirated, but gastromeal is aspirated, and this is safer for if there is a leak. So you are not at the risk. Also, mediastinitis will be a complication if barium injected. So, or given to the patient. So if the patient given a barium with anastomotic leak, this will cause mediastinitis. If the patient after surgery is unwell, he may aspirate. So the patient may be having a pulmonary edema for gastrography. So we are going to use gastromeal. Okay, thank you. Okay, another one. 59-year-old female has worsening dysphagia to solids in the mid-sternal region. She is a smoker. The clinician team are requesting an investigation to assess the esophagus which options are approved. Gastrografin, gastromiro, barium. Which one? C. Yes, of course. So we need to assess the mucosa, we need to assess the lumen. There is no risk of perforation, there is no risk of aspiration, so we are going to use barium. So this will have a better mucosal detail, especially in double contrast with CO2. Okay, so if you have a double contrast option or this barium 250%, you will use it as a barium swallow or barium meal. It will give you a very good details about the contrast of the mucosa, so then you can use it in the as a investigation. I think similar questions are coming, and this is how to deal with this solid information. I know most of you know found this lecture very noisy, and in the exam the questions are very noisy. Why? Because it depends on the solid information you get. What is the indication? What's the contraindications? What is the next? When I will use this, and if you're not memorizing this one and making a practice like this one to extract the information on a clinical scenario, it will be tough in the exam. So you need to prepare yourself with this one, and we are trying to do this through our course. But it's very hard job, even for us. Okay, an 82 years old lady has become acutely dysphagic to solids and is drooling. She has chronic obstructive pulmonary disease and is on oxygen. She has failed to tolerate endoscopy. He told you that endoscopy excluded. And the team looking after her are requesting an urgent contrast examination to see if there is physical obstruction. Which organs are included in the exam? It will be one option. So which one? Okay. There is high risk of aspiration. Yes, there is high risk of aspiration. Why? Because the patient is on oxygen, it have respiratory problems, and it's all patients. There is risk of aspiration, so we are going to use gastromiro. Okay, so it can be very in the exam. It's very acutely dysphagic, solids, and it's drooling. So he's telling you the best patient may be aspirate. So you need to use safe contrast media, especially in this situation. So this is a very tricky exam question. This will be can notice this one. Just leave this one. This is similar as others. And this one also. We need to go to a more complex one. Okay, which of the following statements regarding barium follow-through are true? It's the best performed immediately following the barium meal. A beam or pneumocolon technique can be employed to provide double contrast views of the terminal ileum. It's a low radiation dose examination. It's necessary to give full bowel preparation to ensure the small bowel is empty. Yes, B. Yes, this is what we told in the previously. It's very important and can come in the exam. Yes, because if they are going to ask you about this examination, this 2A, it's the main stage of evaluation of your deep knowledge in the radiology. That's why 2A examination is quite tough, because you are required. It's required to be have a wide knowledge about radiology. So they may ask you a questions like this one. maybe. Okay. So barium follow-through is best performed as a dedicated examination, not this is so you are not using a barium meal and then doing barium follow-through. Okay, so barium follow-through is a different technique. So you are using each one for each application. Okay, although often not routinely necessary, it's not routinely necessary. This technique can be used problem-solving tool in certain cases to solve the problem of the terminal. So this is one. Okay. Another question. Which of the following statements regarding small bowel enema are correct? Small bowel enema and interior crisis are two terms used to describe different examinations. Small bowel enema gives particularly good images of the duodenum. Methyl cellulose is a negative contrast agent used for small bowel enema. Patients rarely find catheters insertion unpleasant, rarely. It's essential to have a dedicated small bowel enema pump. They are asking about the technique itself, and it can come in the exam. Okay. Interior crisis is used in North America. It's correct because they are the same entity. One is used in North America and the other is used in Europe. The catheter is inserted beyond the duodenum, so the duodenum is the best is not in the field that you are going to examine by small bowel enema. So enema because you are inserting the catheter. So that's why they called it enema. So the duodenum is best imaged during the dedicated duodenal barium meal. So if you are going to examine duodenum, you can use barium meal, and small bowel enema or interior crisis will be used through a catheter inserted, maybe introduced more after the duodenum, so you are going to start in the duodenum injecting the contrast. Methyl cellulose provides a negative contrast when used with the positive contrast barium to give a double contrast study. You are going to do a double contrast study, you are using methyl cellulose as an agent for this one to give a contrast between the positive contrast, and it will act as a negative. Patient will find this catheter is not good one, and the pump is not routinely used, especially if you are doing a single pump. Regarding investigation of colonic pathology, which statement is correct? The double contrast barium enema is a screening investigation of a choice for bulbosus coli syndrome. Colonoscopy is the investigation of choice for checking the integrity of post-operative low rectal anastomosis. Double contrast barium enema is a satisfactory method for the pre-operative investigation of the colon in patients with a non-rectal carcinoma. Water-soluble contrast agents are used for the investigation of suspected anastomotic leak. Constipation is a risk, particular to the water-soluble agents. D. Okay. C. D. Okay. D. Okay. D is correct, yes. Why this one A is incorrect? The possible large number of polyps, multiple biopsies are required, and therefore colonoscopy is required. So, as we told this information, in inflammatory bowel disease and bulbosus coli syndromes, we are not using contrast studies as a first investigation, especially if there is except if there is any indication for this, like fistula. So this is not routinely used as a first possible. The single contrast enema is the best investigation, not colonoscopy. Okay. The risk of perforation from colonoscopy would be too great, especially if it's low rectal. There is post-operative low rectal anastomosis. Maybe if you are going to introduce a colonoscopy, there is a risk of perforation. So using single contrast enema is best one. CT colonography or colonoscopy satisfactory than this double contrast barium, because this will be an avenue. We know that the patient have rectal carcinoma. So what is the use of double contrast barium anyway? It will be a very primary study. We are going to investigate the patient with it. But at this stage, we know that the patient have a rectal carcinoma. We need more advanced imaging to see intraluminal and extraluminal organs. So the CT or MRI and colonography will be the best choices in this scenario. And water soluble is an investigation of choice if we have a suspicious of anastomotic leak. Water soluble agents will cause diarrhea, in fact, not to have laxative one. Barium will have constipating effects. Okay, 75-year-old man within 3 months following a high anterior resection for malignancy with increasing constipation, pelvic pain, and raised inflammatory marker. Which of the following statements is correct? Colonoscopy will allow assessment of both intra and extraluminal tissues. Double contrast barium enema is an appropriate investigation. Single contrast enema is the most appropriate radiological examination to evaluate the anastomosis. MRI colonography or MR colonography is an investigation of choice. CT colonography is indicated. So what is the main problem here? What happened? The patient had 3 months following a high anterior section of malignancy, and he having constipation, pelvic pain, and raised inflammatory markers. So what is the most likely diagnosis here? You are suspecting. And then you will choose the investigation regarding this one. And this is one of the complex questions in the exam coming. They will ask you in the first one about the clinic, give you the clinical scenario to give you opportunity to think about the disease at first, then of the pathology, then you choose the next step or the modality of choice depending on your analysis of the scenario. Okay, you are going to use single contrast treatment because you are suspecting the fistula tract or maybe a structure due to any cause or local recurrence. This is BSA, and you can use also water soluble if you are suspecting leakage or something in this So colonoscopy, the only assessment in the lumen. Okay, double contrast enema is no longer indicated. خلاص finished. Okay, as I told you, this will be used in the primary investigation as a primary investigation in the beginning. Single contrast enema will allow safe evaluation for fistula structure or local recurrence. MRI colonography is still research investigation in UK. It's not used as a routine investigation in the clinical practice. CT colonography is not indicated as a first-line investigation. Use endoscopy or single contrast enema. Because in UK they are not using CT. Maybe using because there are many waiting lists, because patients very long waiting lists for some things. So sometimes they are going to more practical investigations that give quick evaluation of the patient. 80-year-old female presents with altered bowel habit and rectal bleeding. Current guidelines state that in this case, double contrast barium enema is indicated. colonoscopy without bowel preparation will allow accurate evaluation of a large bowel. MRI colonography is best for extraluminal evaluation. Single contrast enema will allow good mucosal assessment. CT colonography is a good colonoscopy for detection of colorectal cancer. He is asking about the current guidelines. Okay, the current guidelines, there is political beliefs, they are starting to shift to CT colonography in UK. They are shifting now in most of the centers to use it if there is suspicious to colorectal cancer in the diagnosis to allow evaluation of others. And here in this one, the prohibited one is because the patient have without bowel preparation, so this is excluded. So the colonoscopy and the CT colonography are now competing each other in the UK for the screening and for the evaluation. Okay, because also still colonoscopy is having a risk of a problem and also having a waiting list, very long one. So they are competing each other in UK. And they are expecting in a few years it will be the modality of choice in the screen. So here, double contrast menu has been suppressed in the guidelines. The patient will need bowel preparation and distension for mucosal assessment at scope. The CT and MRI are equally good at extraluminal assessment. Single contrast can't give good mucosal detail because it will have water-soluble contrast. And CT colonography is a good as colonoscopy for detection of colorectal cancer. And this is about abdominal graph. Which of the following, which one of this projection is routinely performed in suspected mechanical bowel obstruction? Left lateral decubitus projection, erect X-ray, supine examination, erect chest X-ray, supine short through projection. C, okay. Only supine examination is routinely performed, only, because many of colleagues are going to choose erect. Okay. Which one of the following options is not a sign associated with perforation on the supine abdominal radiograph? Is not a sign associated with perforation on the supine abdominal radiograph. Okay, no answers? Yeah. Yes. Okay. Silhouette sign is used in the abdominal and the thorax for the evaluation of mediastinal lesions. And so this is not used in the abdominal radiograph. So regular sign, coronal sign, coronal diaphragm sign, and football sign, cap sign. All these are used or signs that will appear in abdominal radiograph. Okay, very good. Okay, left lateral decubitus and short through projections can be used in which of the following circumstances? As a screening tool for acute abdominal pathology in children, as an alternative to standard supine anteroposterior projection, as an alternative to erect abdominal anteroposterior projection, as a lower dose alternative to CT examination. Any answers? D. C. Could be. A. Oh, quite different answers, in fact. Okay, the correct answer is B, because I told you during the session that we are going to use left lateral decubitus and this one for babies especially, okay? Because we can do erect for the babies, okay? We can do erect for the babies because we are imaging neonates and child supine in supine position. So if we are going to fix him in the sitting position for he can't stand even. So we are going to use lateral decubitus instead of erect thumb. So in children, we are going to use this as an alternative methods for erect, in fact. Okay, so in adults, it's quite difficult. You are not going to use lateral decubitus except if you failed to do an erect. Okay, but you are going to do supine if you are suspicious of an you want to assess the patient to check any free fluid, you are going to do an erect one. If you fail to do an erect one, you can move them to a left lateral decubitus. But in a child, after supine, you use left lateral decubitus as a next step. Signs of sigmoid, this is quite away from the next step, but let us give the eyes here. Signs of sigmoid volvulus on an X-ray, abdominal X-ray, would include which of the following? حاجة تقول لك إن ده sigmoid volvulus. Yes, loss of the hysteroid polyps. So this is the signs of the sigmoid volvulus. Other signs: liver overlap sign, left flank overlap sign, apex under the left hip diaphragm, apex above the 10th thoracic vertebra, inferior compress of the left middle line, air fluid level, absence of vertical gas. Okay, I think we finished the questions related to this. I know that it's really quite long. I'm so sorry for that. And it was very tough. I know it. But it's important to have this wide knowledge about the investigation and next step. You must prepare yourself for these questions. It's very tough in the exam. If you don't have much knowledge about it, I think it's very hard to pick the correct answer without concentration, without the wide knowledge about these things. We are trying to do our best through our course to provide this during it. We are improving it as we can. So thank you all for attending this, and we'll see you soon and later in other free activities. Thank you very much for having me. I'm Dr. Mohammed Amin. Thank you very much. See you and have a good night.